How are you, B?
Doing well. It's finally very warm in Buffalo, which I'm very grateful for.
All right. How's Ecuador, Denise?
A mix. We submitted the proposal, and we are waiting for that. We are also working with another province that is very close to the Guayas province, the initial region that we chose for the LDS proposal. They are building an inpatient facility to treat mild cases of COVID, to prevent them to go to the hospital, but because in that province there's only one hospital. So we were asked to train the nurses and physicians that are going to be working on that facility. So we are waiting on them on when to begin the training, because they were not, they haven't reached out to us on that. But they are planning on opening in June, but they haven't tell us when. And also they are interested they requested us to train healthcare promoters, because they are doing medical brigades within the province. So they gave us the topics that they are interested in for us to give the training. So we're working on that. I already reached out to Dr. Mena Laura and other medical volunteers to work on this training. So of course it's going to be online training. So we are working on that, for that to start as soon as possible. Yeah, thank you.
Thanks.
So I'll keep you updated. Yeah, thanks.
Right.
All right, Denisse, we're all set. Thank you for your patience.
Okay, so let's begin. Good morning, everyone. We are here today to talk about the mental health aspect of coronavirus pandemic. As we all know, this pandemic has resulted in high levels of stress and trauma among frontline healthcare workers, including physicians, nurses, and all frontline workers who care for themselves and for the health of their families and loved ones. And because of that, there has been anecdotal reports on increasing of suicides, PTSD, anxiety, and depression. And this has been very challenging for us in different ways. That's why we have today two experts on the topic. It is my pleasure to introduce you to Dr. Zaher Sahloul. He is the founder and president of MedGlobal, a medical international nonprofit funded to reduce healthcare disparities by providing free healthcare to refugees and displaced and other vulnerable groups among the globe. He participated and oversees medical missions to more than 14 disaster region areas, including Syria, Yemen, Bangladesh, Kurdistan, Lebanon, Colombia, and Gaza. Under his leadership, MedGlobal has partnered with local communities to build resilience in the face of disasters and wars, using technology and innovation and focusing on the training of local healthcare providers. He is a full-time critical care specialist and an associate clinical professor at the University of Illinois, a humanitarian and a strong advocate for refugees and victims of disasters, including his homeland, Syria. He has been awarded the Chicagoan of the Year Award in 2016 for risking his life in medical missions in Aleppo, the Heroes Among Us Award by the American Red Cross in 2017, and the UNICEF Chicago Humanitarian Award in 2017, the Commitment to Change Award by the National Immigration Justice Center, and the Robert Kirshner Award for Global Activism by Heartland Alliance, among other awards and recognitions. So thank you, Dr. Sahloul, for participating in this webinar. And our second speaker is Dr. Steve Weine. He is the Director of Global Medicine, Director of the Center for Global Health, and Professor of Psychiatry at the University of Illinois at Chicago College of Medicine. For 30 years, he has been conducting research both with refugees and migrants in the US and in post-conflict countries, focused on mental health, general health, and violence prevention. His research mission is to develop, implement, and evaluate psychosocial interventions that are feasible, acceptable, and effective with respect to the complex real-life context where these risk populations live. His work has been awarded multiple grants by the NIMH, DHS, and this work has resulted in more than 130 publications and 2 books. He has been awarded 2 Career Scientist Awards, the Services-Based Research with Refugee Families from the National Institute of Mental Health, and Labor, Migration, and Multi-Level HIV Prevention from the National Institute of Child Health and Humanitarian Development. Dr. Weine is also the 2020 recipient of the Abraham L. Halpern Humanitarian Award from the American Association for Social Psychiatry. So thank you so much, Dr. Weine, for being here in this webinar. Dr. Sahloul and Dr. Weine, the floor is yours.
Well, thank you very much, Denisse, for the nice introduction and the nice words. And I'm really honored to be in this panel with Dr. Stephen Weine, who is a role model for all of us in the global health community, for his pioneering work and his leadership. And this is a dear topic to my heart, not because I'm a psychiatrist, and I will defer the heavy lifting to Dr. Weine, but because I've been involved in many disaster regions where healthcare workers have been overwhelmed with the scale of crises and disasters in areas like Yemen, Gaza Strip, Syria, of course, Bangladesh, Colombia, Venezuela, Puerto Rico following the Hurricane Maria, and many other places. And now we are in the midst of this pandemic of COVID-19, which we have not witnessed, the world has not witnessed in the last 100 years. I've been part of response to pandemics in Chicago. When I started my training, it was the peak of the HIV pandemic. As you may remember, that was a really stressful time for us because that was a new disease. We were discovering new things every day. The scale of the HIV crisis, especially in the beginning, was huge. Treatments were not available. Patients were young patients were dying, and we felt helpless for sometimes. Also during my training and later on during my professional life, I've been part of response to other outbreaks and pandemics, including the hantavirus pandemic, the H1N1 influenza pandemic, which led also to a lot of critical care illnesses among young people and death. The SARS pandemic, Ebola pandemic, although we did not witness it here in the United States, but we knew what was happening in West Africa and the scale of the crisis and how it did overwhelm the system in several countries in West Africa. In a recent medical mission that we had in MedGlobal to Sierra Leone, Sierra Leone was one of the epicenters of the Ebola crisis. We did some medical training and surgeries and saw patients in a city called Botown. And we were told that 1/3 of healthcare professionals in Sierra Leone died because of the exposure to the Ebola virus and because they got infected and there were no treatment. We're seeing the same things happening with the COVID-19 virus. This is very serious new virus. We do not have any specific treatment yet to it. We do not have any vaccine. It's spread all over the world. We have more than 5 million patients who are infected, and the numbers are increasing every day all over the world. Of course, in the United States, we have about 1.6 million people who are infected so far, and more than 100,000 people who died. I mean, these are astronomical numbers. If I told you 4 months ago that we're gonna have 100,000 people dying in the United States because of a new virus, no one will believe me. And no one believed really the early warnings from the healthcare communities about the scale of the virus until they witnessed the impact of the virus and how it's spreading quickly and how is it causing a lot of death, especially among vulnerable population. In our vision in MedGlobal is to create a world without healthcare disparity. And unfortunately, like many other diseases, this virus also, it's creating more healthcare disparity, and it's affecting the population who are or already have poor access to healthcare, who have more comorbidities, causing more death among them. And it's well-known fact right now that African American patients, Latino patients in the United States have higher percentage of death, even though that they represent lower percentage of the population. I would like to comment about the parallels between the experiences in disaster regions and how it overwhelms the healthcare community and what's happening right now in the pandemics. And I would like to mention a story, which is a real story that happened during the Syrian crisis. One of my colleagues who was an emergency room physician in a small hospital in Al Ghouta in 2013, he woke up in the middle of the night with a large number of people flooding the emergency room. He had 20 beds in that hospital in Ain Terma, and he had 700 patients over a few hours, all of them having similar symptoms. They had shortness of breath, they were suffocating, they had cough, they were complaining of chest pain, young and old, men and women, children and old people, all of them having similar symptoms. Because of exposure to sarin gas at that time. It was a chemical weapon attack that led to many deaths. In the morning, and this physician, Dr. Sahloul, he had to make very difficult decisions. He had only few ventilators in the hospital. He could not save everyone who came to the emergency room. He treated them with what they have at that time: oxygen, bronchodilators, antidotes, atropine, but he could not save everyone. And he had to make decision which one he could save and which one he could not save because they were very sick or they were terminal. In the morning, he had 144 people who died in his emergency room. So that was very traumatic experience to Dr. Sahloul. Until now, he checks on his children every morning before he goes to work to make sure that they are breathing. A couple of members of his medical staff got also affected because they did not have proper PPEs to protect them from sarin gas. And by touching the patients, they got the symptoms, they got the sarin gas. One of them died. So what happened in Syria with the civil war, with the use of chemical weapons, also with the endless bombing that we're seeing also in Yemen and other places, where physicians are overwhelmed by the number of victims that they cannot save all, that creates a lot of stress on physicians. When you have a crisis or disaster that overwhelms your medical system, your ethical principles for making decisions switches from the standard of care to the crisis standard of care, which is totally different. So in the usual situation as a physician, you direct your attention for every patient, you want to save that patient's life. And you have a lot of resources to help you. You have nurses, you have medications, you have ventilators, ICU, especially here in the United States. But when you have a pandemic like the COVID-19 pandemic or disaster in other areas, you cannot save everyone. So you want to select which patients you will be able to save. And this switching can cause a lot of stress. The other parallel, of course, is the lack of protection for healthcare providers. We've seen it in disasters in Syria and Yemen, and we're seeing it right now with the COVID pandemic, where you have a shortage of PPEs, N95 masks, face shields, and other protective devices or personal equipment. In my hospital, we are asked to use the N95 mask several days and keep it in a brown bag because we do not have enough N95 masks, and that is happening in many other hospitals. We've seen the impact of pandemic on healthcare workers. In China, you had physicians who are dying, who died because of the COVID-19, including the physician who, Dr. Lee, who voiced the early warning about the crisis. In Italy, 18% of the people who were infected were healthcare providers. In Spain, 10%. In the United States, we had hundreds, thousands actually, of healthcare workers who were infected, and we had at least a couple of hundreds who died because of lack of protection from PPE. So all of this is adding also to the stress related to the COVID-19. In my specialty in critical care medicine, my society and other societies before the crisis were quite aware of a syndrome, we call it burnout syndrome. And burnout syndrome is a condition that is related to stress related to the work, the fact that we are making difficult decisions, life and death, the fact that you have work overload, the fact that you have no control on the outcome. All of these things are adding to the stress that physicians and nurses, of course, and respiratory therapists are facing. Burnout syndrome manifests itself not necessarily with PTSD and depression and anxiety, but it manifests itself with three major symptoms. The first one is emotional exhaustion. So nurses, physicians, and respiratory therapists feel exhausted. They cannot empathize with patients. They feel tired, fatigued. So that's one class of symptoms. And the second one is called depersonalization. Depersonalization means that people tend to become cynical. They have negative attitude toward their co-workers. They have negative attitude toward their work. And the third manifestation is low personal accomplishment or low self-esteem. You feel that your work is worthless. You feel that you're not really contributing. You feel that you're not being recognized for your contribution. So these three major collections of symptoms are very common within the medical community, especially certain specialties, emergency medicine, anesthesia, critical care, even before the crisis. In some of the studies, 40 to 50% of critical care specialists, emergency specialists, have burnout syndrome. COVID-19 pandemic has caused also a lot of stress and mental health problems within the healthcare communities. In China, several studies have shown that 50% of Chinese healthcare workers, because of the COVID-19 pandemic, had depression. About 45% have anxiety. 34% had insomnia. and 72% had general stress. So we are expecting to have more problems as the pandemic actually wanes down, because as a physician, and maybe Dr. Weine can expand more on that, or as a nurse, when you are in the midst of a crisis, you are running on adrenaline. So you are focusing on your next patient, you are focusing on your next decision. You're not really paying attention to your mental health. When the crisis ends, and it will end at one point, then you will feel the consequences of the crisis on your mental and physical health. So the World Health Organization, of course, is aware of that, and I'm happy that they recognize this, and they're trying to promote mental health recognition and treatment for healthcare workers. 1/3 of the healthcare worker, according to them, have some type of mental health stress related to COVID-19, but we have to pay attention to it also in our hospitals. Some of the hospitals have started resiliency programs to address this issue, to make sure that our nurses, our respiratory therapists, our doctors are aware of these issues. If they have stress, they can be counseled. They have meditation during the day. Meditation will be very helpful. They have structured breaks during the day, so they don't, so they can disconnect from the overwhelming type of work. The managers in the floor should be identifying early signs of trauma within the nurses or the physicians, and try to provide them with resources for counseling, and many other things that can be done to improve the resiliency of the healthcare community. There are many other things related to this topic. I hope that we can address them in the Q&A session, but I'm really eager to hear Dr. Weine and his insight on this issue. Thank you very much, Denisse.
Thanks very much, Zaher. That was brilliant and really helpful to hear all that you had to say. And it's a pleasure to be able to speak with you and our other colleagues on this important issue. So, first thing, I was thinking about the colleague you mentioned in Syria. That story for me represented courage, commitment, ability to make a decision in an ethically compromised situation, the capacity to manage stress and trauma, and yet to continue being a doctor, continue being a parent. And also, I imagine behind him was a lot of organizational capacity and coordination. And so these are exemplary qualities. These are the qualities that we see today in so many of our healthcare workers in the US and healthcare organizations. We need to identify those kinds of models and try to, as best we can, embody them, institutionalize them, because we're in a different space. Let's be honest. For American health professionals, we are in a different space than we're used to. I think of it like being first responders. I do a lot of work with firefighters and police officers. They're used to being on the front lines. They're used to being exposed to trauma and violence and in emergency and crisis situations. But most American health professionals are not used to that. And so now they're getting introduced to it for the first time, and it takes a toll, and it requires a different kind of skill set to be able to weather that. I also saw an article the other day that America is a country that's never been invaded by by a foreign army. Well, to a lot of Americans, this feels like an invasion, and I'm not trying to make any kind of allusions to immigrants or migrants or anything like that, because everybody who knows me knows where I'm at on these issues. But I'm just talking about the sense of being under siege. It feels like being under siege by a virus that has changed a way of life and caused for drastic changes in how in our daily lives as individuals, as families, as communities, as institutions. That's what people mean when they say that this whole thing is not just stressful, but it's traumatizing. So let me go into a little bit more depth on some of the mental health issues that Zaher alluded to. So it's clear to me and to most observers that in this COVID era, that Americans are having more mental health symptoms than typically, and they're seeking help for these kinds of mental health systems. They want support for that, and yet there's problems with accessing appropriate mental health resources. I think that unless access is improved, then we can expect a wave of mental health consequences and casualties that's no less damaging than the virus itself. But on the other hand, I think there are steps that individuals, that healthcare providers, that organizations, and that society can take to improve the response and make this better. So that's my overall message. Let me kind of like parse that out a little bit. So first thing, Americans are having more mental health symptoms than typically. Zaher, you gave some of the evidence. There's a bunch of surveys that have been done recently. One of them showed that 49% of people are showing signs of depression, and this is contrast with like 37% at baseline. Another survey showed that 45% of Americans say the pandemic has affected their mental health. 19% say it's affected it in a major way. And this impact is felt more amongst Hispanics, amongst Blacks, and amongst women, not surprisingly. We also know that there's a very strong link between economic devastation and mental health problems. And so we have massive unemployment, and there have been models that have predicted that, you know, if unemployment raises by 20%, then we could expect 18,000 suicides and 22,000 overdose deaths from opiates. So these are very, very serious numbers. Let's talk about healthcare professionals for a moment. Like you mentioned, Zaher, a study done in China showed 50% were depressed, 45% had anxiety, and 34% insomnia. A group of doctors from UIC recently did a survey of 2,700 healthcare workers around the world in 60 countries. And they documented that 51% of them reported burnout, like you were talking about. And that's higher than the typical number. The typical number of burnout is somewhere in the 30s or 40%. Interestingly, the level of burnout was higher in high-income countries than low-income countries, which, you know, my interpretation of that is that doctors in low-income countries are used to being exposed to adversity and have developed more resilient coping strategies, like Zaher mentioned, than doctors in high-income countries. But there may be other interpretations as well. But these were some of the numbers I just gave you about percentages of mental health problems. How does that compare to percent of mental health problems in other situations? Well, the general rate in disasters of disaster survivors of post-traumatic stress disorder and other diagnosable conditions is 20%. How about in combat veterans? So people who've been exposed to combat, 20 to 30% are going to have post-traumatic stress disorder or other problems. The US lifetime prevalence of post-traumatic stress disorder is 7.8%. Refugees, like MedGlobal works with refugees. Refugees tend to have like 40 to 60%. So where does that place us with the pandemic? I think it places us somewhere in the, somewhere squarely in the disaster space. Not quite as bad as being a refugee, but somewhere like other disaster exposed populations. People have been exposed to natural disasters. My point is that not everybody who has been exposed to trauma is going to develop a diagnosable mental disorder. They're going to develop other things. They're going to develop what we call like behavior change. Like, for example, they, you know, they're afraid to go to the market. They're afraid to be in public. They don't want to see anybody. They will develop transient emotional distress that may take the form of trouble sleeping or difficulty concentrating, but it doesn't rise to the level of a full-fledged psychiatric disorder. So, you know, one lesson that I take away from this is that we have to do a better job understanding what's the difference between just stress, between behavior change, between transient emotional problems and diagnosable mental disorders. Another thing, well, why do we need to do that? Because we need to be able to tailor our interventions appropriately at different levels, because one size doesn't fit all for the kinds of distress that people are having. So the second kind of big point I want to make is that, you know, there's signs that Americans are seeking more mental health resources. And there's evidence from different kinds of surveys on this. A national mental health hotline said that their call rate was 40% higher now than it was last year at this time. The National Alliance on Mental Illness said that they're getting also 40% more calls and emails with mention of suicide or self-harm. So that means the rate of suicidal thinking and behavior is 40% higher in people who are calling into hotlines. We also know that more Americans are using alcohol to self-medicate for their distress. Online alcohol sales increased anywhere from 55 to 300% in March and April. So these are signs that people are reaching out for help, but maybe not reaching out in the right way, or maybe not getting the help that they need. In our field of mental health, you know, which includes all subspecialties, psychiatry, psychology, social work, nurses, whomever else. One reason that we're very optimistic is that we know that we have good evidence-based strategies that can help people. And those strategies fall along a whole spectrum from what we would call like self-care strategies, like deep breathing, something we call grounding or progressive muscle relaxation, to things that I would call like lifestyle strategies, like yoga, mindfulness, exercise, to actual mental health treatments like cognitive behavioral therapy, and then for some medications. Oh, and I left out psychological first aid, which is another kind of intervention that could be done in an immediate emergency context. As you can tell by the things that I have just mentioned, only some of these depend on delivery by mental health experts. Others can be delivered by yourself, to yourself, or by a parent to a child, or by a spouse to another, or by a primary care doctor, or a teacher to a student. And so this is one of the important lessons we've learned in the field of global mental health, where we're concerned with how do we deliver mental health in low-income countries where there's just simply not enough mental health experts to go around. Well, what we've learned is that you can still do it. You can do it by exposing people to these mental health strategies and letting lay healthcare workers or primary healthcare workers or teachers be the deliverers instead of the psychologists or psychiatrists. Well, I think what we've come to in the United States, which is a rich country with plenty of mental health professionals, is that we need to also open ourselves up to this range of different strategies in order to meet the range of different mental health and psychosocial needs that people have. Because honestly, you know, a lot of people who are suffering, including those healthcare workers that you mentioned, Zaher, they're not going to want to go to seek traditional mental health services. They either don't have the time, they don't have access for one reason or another, or it's just not part of who they are. So the challenge upon us is to find other ways to deliver appropriate kinds of supports to them. So I think one of the most exciting ways right now is through the use of digital or web-based mental health resources. So I invite any of you to go to the City of Chicago's website. If you look up like City of Chicago, mental health, services, COVID, you'll find your way to a resource site. And on that resource site, you can find, you know, dozens of different interventions that are free, which can teach you these kind of strategies that I mentioned. And you also can find ways to assess yourself for what's your status. And you could find different kind of educational explanations. What is stress? What is trauma? What's the difference? What is burnout? So burnout, trauma, stress, they might feel the same, but they're not the same. And they call for different strategies. So we need to educate people so that they can best make choices for themselves. So I think that this is very exciting that places like the City of Chicago and many other municipalities and healthcare organizations and NGOs are putting this stuff out there. In fact, there are just hundreds of different sites available right now for all kinds of mental health problems and all kinds of subpopulations that are accessible to the general population. And yet we're also learning that you know, the web doesn't solve all of our problems. You know, I think we've learned that in many aspects of our life, right? So we've learned that these web-based resources work better when you have an actual person who's supporting you and guiding you through them. So that person, again, doesn't have to be a mental health professional. It could be a peer, it could be a supervisor, it could be a teacher, but who's checking in with you and saying, hey, is this working out for you? Is this helping you with your needs, or do you need something else? So I think that a challenge is to be able to provide some kind of blended services where you have actual in-person support with web-based tools used adjunctively. I think that the other interesting lesson that we're learning from these web-based tools is that the people who go online to use them are, again, not necessarily the same people who would be seeking out in-person mental health care. But that's okay. That's okay because, look, the honest truth is we have what's called a mental health treatment gap. Well, we have it around the world, and we have it in the United States. Around the world, 80% of people who have diagnosable mental health conditions are not receiving evidence-based treatment. But in the United States, what do you think that number is? Well, it's appallingly high. It's 50%. So 50% of people who have problems are not getting the help that they need. And I'm not just talking schizophrenia. I'm talking depression, panic disorder, anxiety, problems with suicide, learning problems in kids, drug and alcohol abuse. So if some of those people can get helped through some combination of online resources, this would be a good thing. They don't all have to go for traditional mental health services. So I think that this, in a way, is an exciting time and an opportunity to deploy these kinds of digital resources and see what kinds of help we can get. So I think that especially applies to healthcare professionals. I think that very busy healthcare professionals might especially find usefulness in some of these digital kinds of supports. So I'm encouraged that hospitals like UI Health are making available call-in hotlines and other kinds of resources for their healthcare workers. I think we're going to have to do more of that kind of thing. There is an increased demand for services, and if we don't meet that increased demand, what's going to happen? Well, the worst case scenario is increase in suicide and opioid use. And I would remind everybody that in 2018, there were 50,000 documented suicides in the United States and 67,000 drug overdoses. That's 110,000 people. That's more casualties than COVID so far. So the worst case scenario would be worsening of those. And we've seen some very troubling examples of suicide by doctors in New York City already. So the question is open. Are we going to meet this demand? Are we going to find a way to meet this demand of increased mental health support for healthcare workers and for people in the community? Or is it going to add to the casualties? I'm hoping that we step up and find ways to meet the demand. I'll stop there.
For your intervention.
Denisse, we cannot hear you.
Can you hear me now?
A little bit.
No.
Thank you so much for your intervention. Any question, Dr. Sahloul, for Dr. Weine?
Well, I think we have some questions came on Facebook Live. My question to you, Dr. Weine, is you mentioned the resiliency of the healthcare workers and that some people are more resilient than others to kind of weather the storm, whether it's a pandemic or disaster or stressful work conditions. What makes a nurse or a physician more resilient than others? Yeah, I mean, this is something that is very important because I've noticed the same thing that you've noticed, that, you know, in Syria, for example, in Aleppo or Idlib, you would expect healthcare workers to be depressed, to have all kinds of anxiety, PTSD. Some of them do, but the majority don't. Even in the refugee camps, you know, talking about refugees, you go and you see children playing and laughing and having fun, even with the stressful situation they are living through. So, what makes someone more resilient than others? What practices you would recommend for any person, not only healthcare worker, to improve resilience?
Thank you for that question, Zaher. I think that's a critical question for healthcare workers and for all of us as human beings. And I don't think we know enough of the answer from a science point of view about the resilience in healthcare workers. So that's a future study that we need to do together, I hope. But I could give you some principles based upon what we know about resilience from other situations. In no specific order. One is a sense of hope and optimism that no matter how bad things are going to end up okay. And people get that sense of hope and optimism from different places. Some people get it from faith, from religion. Some people get it from arts or music. But I think that the sense of optimism and hope is very important. Everybody has to find a way to sustain that and to make that part of their daily lives. Another is support. Support from colleagues, support from family, support from friends and peers. You need to stay engaged with people. You cannot let yourself get isolated or cut off. So building that into your daily life is critical. Another is organizational support and training, especially for healthcare workers. None of us can do what we do on our own. We require hospitals and clinics and professional societies to stand with us and behind us. And so having those networks active and giving us knowledge and skills and retraining, that's very important. And another is family. Like first responders, healthcare workers are now going to face difficult issues of how much do I share with my family or not. The most difficult situation is when individuals get cut off from their family because they feel like they're having this really intensive traumatic experience in their work, and they don't want to bring it home and share it with their loved ones because their loved ones don't want to hear it. It'll make them feel even worse. So they keep it all inside. And yet their loved ones can see that they're in distress and they're suffering, and their loved ones want to help them. And then when their loved ones reach out to help them, then they kind of push them away and they make their loved ones feel that they don't love them. And it can lead to a cycle of distancing and resentments. And it's very important that healthcare workers learn from first responders about how to appropriately share with family and how to be there for your family in a way. And families also need information about the unique stresses that healthcare workers are going through, and they need to learn to be flexible in ways that they've never been before. Families now are legitimately afraid, am I going to get infected by my husband or my wife bringing home this virus? And so families need to derive strategies for how to do that. These things are manageable if they're talked about and worked on. So those are some of the answers, Zaher, but I think we have a lot to learn in this space. You're muted.
Yeah, this is very helpful, and especially when the issue with families. I mean, I've seen nurses who refused actually to go home, and they stayed near the hospital. They rented an apartment or stayed in a hotel because they did not want to go and infect their family members. And especially, you know, now with the pandemic. So this is a new challenges that family members do not understand. And of course, many people are scared of getting infected. So drafting a strategy and making sure that people share information within the family, and how do you communicate to your family the challenges that you are going through at work is very important. I mean, I myself, when I come home, I try not to avoid talking about work, kind of trying to compartmentalize things, but that may not be the best strategy sometimes.
Well, there is no one strategy. These are principles, and I think we all need to learn from experience and from trial and error. I wanted to refer back to one other thing that you said when you talked about a kind of longitudinal perspective on this. You know, right now we are in we're in that surge or decline phase of the COVID epidemic. So in some communities we're still going up or we're plateauing, and others we're going down. But if you look at this from the point of view of a disaster, disasters have multiple phases. They have the what called the response phase, that's what we're in now, then a recovery phase, then a mitigation phase, and then preparedness phase for the next disaster. We're going to be, and this is assuming that there's only one spike. If there's only one spike, we're still going to be in this for many more months, and we need to take a long-term perspective. So it's when the surge is over that we're likely to see even more mental health casualties of burnout, depression, alcohol problems, substance abuse. So we're not out of it just because the number of infections has gone down. And we need to really think about what kind of strategies as individuals or as families or as healthcare organizations do we want to put in place to build supports for our people long term. I also think a lot about medical students or other healthcare professional students who are kind of really involved in this, but they're also having major disruptions to their training. So they're kind of engaged and not engaged. And at some point they're going to be on the front lines like everybody else. And so what kind of lessons are we teaching them? What kind of skills are we giving them to manage these kinds of disruptions to the way they thought it was going to be? I think it's very, very important that we be sharing with our students and our trainees the right kinds of strategies and skills so that they're prepared for the future.
So you mentioned this, and many healthcare professionals believe that there will be a second wave in the fall or sometimes in the winter, which may be even worse than the first wave, especially if we do not have a vaccine, or I don't think that we've reached herd immunity yet. I mean, most estimates says that only 5%, and this is a higher number than probably is, of the population have been infected, 5%. That means 95% have not infected with this novel virus. So in preparation for a potential second wave, what would you recommend that hospitals and administrations, organizations should do to basically address the fallouts from the first wave and prepare for the second wave?
Mm-hmm. Do you mean from a mental health point of view, or from
yes, from the mental,
yeah.
From perspective
for one,
of PPEs, but
well, sorry, my cat is walking around here trying to be a part of this call, so I look a little distracted, but I'm with you. Look, first thing, total lockdown is not sustainable. It's not sustainable in the US, and it's certainly not sustainable in low-income countries or in refugee camps where people depend on day laborers just to be able to eat. So we need more precision approaches, like some countries are trying, like Sweden, you mentioned earlier, Zaher, where there's capacity to do early identification and contact tracing and surveillance and isolation so that everything isn't shut down. And that would also lead to a relaxation of stringent social distancing, which has a lot of unintended psychosocial consequences in terms of isolation of individuals and families, increased rates of domestic violence, increased rates of child abuse, which then have other adverse consequences. But given the high likelihood of repeat waves of infection, I think that we need to anticipate that healthcare workers are going to be stretched beyond what they're even stretched now. And so doing whatever we can to ease the burden on them, ease the burden on families, provide additional supports is what's needed. I think that there should be layers of supports. There should be emotional support hotlines. There should be web-based resources. There should be social workers going around and talking with groups of trainees or doctors in the ICU and making them aware of impact of stress and trauma and what they can do about it. And there should be better and easier access to traditional mental health services, counseling, family support, substance abuse support, suicide prevention, things like that. It's too hard to get your way into those treatments now. So I think that our healthcare organizations need to get better at helping our people to do that. And at the broad general level of the community, we have, a broken and fragmented mental health system where people don't have enough access to services. And I think that we're going to see the consequences of that. And we're way behind, just like we're way behind in our public health response to this virus, and it's showing that vulnerability. We're way behind. The federal government and dismantled the community mental health system many years ago, and what we have left is fragments. And so it really calls for renewed efforts at a federal governmental and state governmental level to build back those capacities. That's going to be the challenge of a generation, though. That's not just the challenge of how to respond now.
There is a question from Verpaksha Haravi, and she's from Spain, I think. She's saying that the expectation is COVID may follow the Spanish flu trajectory. No, she's not from Spain.
He's from India. He's from Bangalore.
Yeah. How should mental health professionals balance between general population care and healthcare workers' care without getting into burnouts themselves? This will be on a long term. So how? Yeah. I
mean, in the United States, I'm not sure if he's asking the United States or in India, for example, or other low-income countries. In the United States, we're fortunate. We have a lot of mental health professionals. We have enough mental health professionals to be able to address both of those needs. We don't have to make that choice, I don't think. The question is, do we have a system of care that will support that? And do we have, in system of care, meaning do we have collaborations between mental health experts in places like UIC and community-based organizations? Say, you know, a couple miles from UIC where I work, there's very high migrant populations from Mexico, from Latin America, who have practically no access to mental health services, yet great needs. So how can we help to direct expertise and services in that direction? That takes funding, that takes building a new system. In lower income countries, I think it's more challenging, but I believe that if we're going to have a functional healthcare system, we have to invest in supporting healthcare workers. It would be very, very self-destructive to not help the people who we need to sustain the system. So I think it should be a priority everywhere to support healthcare workers who are on the front lines of this. And that means with mental health and psychosocial supports, but it also means training, PPE, building, having the right kinds of organizational coordination, temporary housing, maybe hazard pay, not decreasing the pay, not laying people off. These are the kinds of things we're hearing about in countries. So all of those kinds of things are absolutely necessary. Zaher, you may have an answer to that too. I don't know.
I think leadership, it comes really to leadership. And I think what we've seen in many countries in the world is failure of leadership at the national level and state level and so forth. I mean, what's happening in the United States, frankly, is shameful to me. And what's happening in Brazil and other countries that did not take this pandemic seriously enough is also shameful. I think we have really to make sure that our leaders are properly educated. They're able to make decisions when we have a crisis. We will have more crises. The world is getting more complicated. We have climate change. We're going to have more disaster. We're going to have more competition for resources, more new viruses. This is not the first virus that is new. to humanity in the last 30 years. We had many new viruses, more pandemics. So it's a matter of time before we head to by the next pandemic. And our leaders have to be properly selected and able to make these crucial decisions. I have a question about meditation, and I think we have a question also from the floor. Maybe Denisse, you can add. You mentioned meditation as a way to deal with to improve resiliency. So, you know, meditation can be prayer, can be supplications, can be you know, reading divine text. What would be the right ingredients for proper meditations that can improve resilience of people who want to do that?
Did you say medications or meditation?
No, meditation.
Meditation. Mm-hmm. Yeah, good. I'm glad you said that. Well, I'm not an expert in that area, but there are people who do have expertise. And I think we're learning more and more about applying meditation or other kinds of mind-body exercises to managing stress, trauma, mental health. I think people need to try out and see what works for them. And I don't think that there's any one, you know, prescription of what is the best. I think there's a range of opportunities, and you try them until you find the one that works best. And it could be that one works best for when you're feeling more depressed, and another works best when you're feeling more anxious or frightened. I don't think we know enough, but maybe we'll learn more through this experience. And so, and I back to what you said before. Yes, I think absolutely. We live in a complicated world where we have not just one disaster, but we have disasters superimposed on disasters and interacting with one another. You know, we have COVID, and we have, you know, the ongoing disaster of poverty and malnutrition in the United States, or migrant crisis on the southern border, or 1 million Rohingya refugees in Bangladesh, and climate change threatening us everywhere. And so we live in a world where we have to think about how they interact with one another. And in some cases, we can learn strategies that can help us across the board, hopefully. In other cases, we find that you know, deficit adds to deficit and makes the situation even worse. And yes, we need leadership, and we need policies informed by science to get us there.
Thank you.
Okay. Any other question before we finish?
We cannot hear you, Denisse.
Yeah. Hello?
Yes, now we can hear you.
Any other questions before we finish this webinar? We have one question saying how we deal with this anxiety for leaving our place right now. If I am afraid of leaving my house, how can I deal with that?
I'm afraid to leave my house.
If someone is afraid for going outside, for grocery shoppings or.
Yeah, well, you know, we hear that all the time. And so at one level, that's appropriate. Do you need to go outside right now? At another level, it could be that there is a kind of fear or phobia that's being added to what's a rational level of fear. And so I would try to problem solve with that person. How much of this is, do you think, irrational fear, and how much of this is unreasonable? Because there are steps that you can take, like a mask and like gloves, and in which you can go into public, you can go shopping, and you could limit your exposure. I think that that's an okay thing to do. And yet I would probably talk to the person and say, what have you done when you've been afraid like this before? You know, and do you have ways of kind of dampening your fears and getting those under control? And I'm imagining that for this person, that they've been anxious like that before, and that if we would practice deep breathing or something like that, and have the person maybe like first go out and take a walk around their block, and then breathe to calm themselves down, and then maybe go and talk to their neighbor but 6 feet apart, and then calm themselves down, and then go in a stepwise way till they're eventually going to the store. But along the way, what we've done is we've built their capacity through deep breathing or meditation or whatever mechanism they want to use to be able to control their emotions. Stress and fear are examples where the mind and the body are racing out of control. But through things like breathing or meditation, you have the capacity to regain control over those emotions so that you can put yourself in those situations. That's what first responders do. That's what athletes do. That's what soldiers do. They're able to control their breathing and control their thoughts and focus on the task at hand. So we can help you to do that if you can learn to do that if you want to.
Thank you so much, Dr. Weine. Well, we have concluded this webinar. This has been very educational for all of us. Thank you so much, Dr. Weine and Dr. Sahloul, for providing your knowledge and experience in this very updated topic. Thank you so much.
Thank you, Denise.
Thank you very much, Denisse and Zaher.
Thank you.
Thanks, everybody.
Dr. Weine,
Be strong and stay healthy.
All right. Take care.
Bye.